Hey, Dr. Drew here with Inspire Cosmetic Surgery. This is Inspire Insights. We're discussing primary breast augmentation. So we went over multiple points with a patient interview and a lot of the things that you need to know about breast augmentation, as well as a demonstration of the exam without showing the patient's anatomy. What I'm going to do now is point out some of the things to make the procedure a little more clear so people understand about incisions, about implant placement, etc. So I'm going to start by showing you that this would be a representation of a normal female anatomy with bilateral, and these are relatively symmetrical breasts, nipple-areolar complexes, and the purple here represents both pectoralis major muscles. So this is the muscle that we're talking about when we're talking about subpectoral implants. Those are implants that go underneath this muscle. So the black breasts are sitting on top of the muscle, and the breast tissue, or the glandular tissue, is sitting over a layer of fascia, which is a fine, thin, tough tissue that sits right on top of the muscle. The implants in a submuscular augmentation go underneath that muscle, and the implants in a submammary or subglandular augmentation, which is less frequently used but gaining some popularity, goes underneath the gland itself, and this muscle stays down. So the implants sit on top of the muscle, and the glands or breast tissue sit right on top of the muscle. So we talked about several different areas to place the incisions. One of my favorite areas, and the area with the least amount of infection, is, and also the least amount of capsular contracture that we discussed, is an inframammary incision. That's an incision that goes right at the breast fold here. It's about 4 centimeters wide. Just to give you an idea, 4 centimeters is exactly this wide. That's 4 centimeters, little shorter than what I've marked right here. So an inframammary submuscular breast augmentation has the incision placed right around the area of the inframammary fold. So it would be on both sides. We'd go through that tissue plane down to the purple part that you see as the muscle. Then we'd actually enter the muscle and go underneath the muscle to place the implant. So we'd create a pocket in the entire area that we want to place the implants, and we design that pocket based on markings that we do, and we design the extent of the pocket usually before the surgery, and then raise this tissue underneath the pectoralis muscle to encompass or incorporate the implant into that pocket. We usually make the pocket about the size that we want the implant. We can also bring that pocket a little more medial, or to the midline here. So this is the sternal notch, this is the xiphoid process, and this is usually the midline in most people. So we can bring that pocket a little bit towards the midline in order to give somebody a little more cleavage. We can only go so far. Some people have a much wider sternum than others. That's the breastbone, or the plate of bone in between the two breasts. And some people's breasts take off at a much wider spot than other people's breasts that may even touch or take off much closer. We can't change that breast position. So some of what you get is what you were born with. We can only adjust it so much. The same thing goes out laterally. Depending on the width of your chest will govern the size of the implant that we can put in relation to the size of your chest. So we do a number of measurements when we're planning on surgery, and those measurements include the nipple distance to inframammary fold, which is from the sternal notch, the sternal notch to nipple distance, which I've marked here, and this is very long, but normally this is about 21 centimeters, anywhere from 18 to 21 centimeters. Right here, this is measuring 29 centimeters, and this is just about the same, around 29 centimeters. So we take those measurements to plan out where a person should be in relation to where their actual anatomy is. And you'll notice when we do an exam, we test where the inframammary fold is and where the nipple is in relation to that inframammary fold. The inframammary fold, underneath that fold, should be around the level of the nipple distance. If the breast is much lower and the nipple-areolar complex is much lower than where the inframammary fold is, that's ptosis, or a droopy breast. So that breast would be, for instance, down here, and the nipple-areolar complex would be down here, and in that case that patient has ptosis and may need more than just a simple breast augmentation or even a dual plane breast augmentation. So let me explain to you what I mean by dual plane. So a dual plane breast augmentation is a way that we can get a little bit of elevation of the breast tissue itself. So through one of the incisions that we make, and we talked about the inframammary incision just now, I'm going to point out to you that we can make a periareolar incision, which has a little more risk. It has a little higher risk of infection, a little higher risk of capsular contracture, and a little higher risk of sensation changes, and a little higher risk of breastfeeding issues. But it is a safe incision. A lot of people use that. I typically prefer the inframammary incision for those reasons of the periareolar incision, and minus the breastfeeding and breast sensation issues, all the other things apply to an axillary incision. The axilla is the area underneath the armpit, and we can actually make an incision in the fold of the axilla. So the axilla is here, and we can actually make an incision right along the creases in the axilla, and we can place the breast implant in that way as well. So then the scars are seen if you raise your arm up high. Most of the time these hide very well and they're hard to see, but they do have the same risks as the periareolar incision. Finally, we can place an implant through periumbilical incision, and when we do that, we actually can only use saline or salt water implants. In that case, we make tunnels from the umbilicus or belly button all the way up to the breast fold. And we use special instrumentation in order to create the pocket, and then we tunnel the implant up into that place and inflate it. That is a bit of a riskier operation as well, as far as infection and capsular contracture, kind of like the other areas of incision placement. So a dual plane versus a regular plane breast augmentation is when we actually release the inframammary fold area of the muscle. So the pectoralis muscle, we actually raise up and we lift that off of its insertion. We create the same pocket that we do with the regular subpectoral implant through a small little opening, and when we lift up this edge of the muscle, the implant goes underneath that. Because we've raised up the bottom portion of the muscle, which doesn't really affect functionality of the muscle, the implant sits a little bit outside of the muscle, or a little bit below the muscle. So when that implant is sitting a little bit below the muscle, it pushes the gland up a little bit, or the breast tissue. So that breast tissue gets a little bit of a lift or a raise when we have the bottom of that implant sticking out from under the muscle a little bit. That's what we call a dual plane breast augmentation, as opposed to making the pocket through a small incision and the entire implant goes through that incision without releasing the bottom edge of the pectoralis muscle. So that kind of encompasses the different incisions that we make, the reasoning behind why we choose certain incisions and why certain incisions are safer than others, and it shows where the subpectoral and where the dual plane implants are, as well as the subglandularly placed implants just under the breast tissue or glandular tissue itself.